Good morning, good afternoon, and good evening, everyone, and welcome to another edition of JAX Live. I'm your host, Rick Huntress, Director of Business Development at the Jackson Laboratory. Today, I'm pleased to have the opportunity to introduce Dr. Jing Zhao, Senior Scientist in our Innovation and Product Development Department. Her focus is the development of new in vivo platforms for the evaluation of CAR-T and bispecific therapeutics. So today, we'll be discussing her recent work with bispecific antibodies in a preclinical efficacy study setting. As a reminder to the audience, please be sure to use the comment box to submit your questions. We'd love to answer your questions as part of this event. Add a comment, or even send us a shout out from wherever in the world you happen to be watching. We're going to answer as many of these as we possibly can, and we'll save a little bit of time at the end of the discussion for those questions. So, Jing, as a start here, we're talking about CAR-T and bispecifics, but let's talk about bispecifics. What are they and what's their primary application?
Hi, Rick. Thank you for the nice introduction. Glad to be here. Bispecifics can be simply defined as synthetic antibody engineered to bind to the two different antigens, epitopes. For example, there's one type of the bispecific we call BiTE, bispecific T-cell engager. One arm, it can target the tumor cells and the T cells. One arm can bind to the T cells through T cell receptor. The other arm can bind to the tumor cells. BiTE as a bridge to bring the tumor cell and T cell together. This way can activate T cells and then cause the tumor cell lysis. BiTE technology hold a great promise to a lot of complicated disease because it has novel functions which cannot attain by through the combination of the parental antibodies. The field is really growing because the recent advance in the antibody engineering. So far, there although only have 2 BiTE products on the market, 20 different platforms available for BiTE creation and development. Significantly, there's actually 85 different BiTE product is in the different stage of the clinical development. This field is really, really growing. In addition, like you asked for the application, they actually have a broad application, not only in cancer, but also in other disease, for example, HIV infection, diabetes, and inflammatory disease. Yeah.
That's really interesting, and it does suggest that this is an exploding field when you only have a couple of approved drugs, but 85 in the clinic. That's very interesting.
Mm-hmm.
So when we work with these compounds at JAX, how do we evaluate bispecifics in a preclinical model system? How does that work?
Because many bispecifics target human immune cells, so humanized mice model is a very nice tool to assess the BiTE preclinical studies. At JAX, we actually have different kind of humanized model. One is PBMC Humanized mice model. Another one is human CD34 mice model. At PBMC model, the major human immune cells is the T cells, and they're mature and functional. In the human CD34 mice model, although they have a more hematopoietic lineage, but not all lineage is fully developed yet. So that's why for T cell engaged the BiTEs, we highly recommend using the humanized PBMC model. I also want to point out there are other advantage of this model. It's relatively simple to make. The PBMC stands for peripheral blood mononuclear cells. It usually derived from the healthy donors, so we can get easily, and then we also can get very, very reliable the humanized engraft rate. Most significantly, like I mentioned before, the T cells in this model is functional and mature. So in fact, and then we using this model to work several BiTEs like EGFR CD3, CD19 CD3. We can evaluate their efficacy and the CRS in the same experiment. That's why we highly recommend using this model to assess the BiTE preclinical studies.
Thanks, Jing. And when we're doing PBMC engraftment, my understanding is we have options for a couple of different strains. I'm mostly familiar with the regular NSG, but are you using some new strains, or what would you recommend for PBMC humanized studies?
Rick, I'm glad you asked this question. I actually just want to talk about this. So we know the limitation of the humanized PBMC model is the development of the GVHD, so-called graft versus host disease. This happened between the human T cells and the mice MHC complex. So recently, JAX actually developed a new NSG line. In this line, they knocked down the MHC class 1 and class 2, so which can significantly delay this GVHD. So our group actually compare the several studies. So we inject the same PBMC, same amount to either NSG or the double knockout, the MHC class 1, class 2 double knockout. We can observe the similar human engraftment rate, similar the cytokine induction. However, the double knockout humanized mice have significant delayed GVHD. So so that's why this model, we think humanized double knockout will be good for bispecific preclinical studies. Yeah.
Can you use other drugs along with bispecifics? Can we get even more complicated systems there?
No, not really. We using this humanized PBMC double knockout model, we can either assess bispecific efficacy in CRS alone, or even we can combination to do combination therapy to combine the bispecific with either checkpoint inhibitors or other small molecules with targeted therapeutics.
Oh, that's neat. So if I had a BiTE, or I work for an organization that has a bispecific or a BiTE, and I want JAX to evaluate that in vivo system, can you help me understand how we would do that, and maybe what the readouts might look like?
Sure. So, for example, if you have the BiTE you want us to check is a target tumor cell antigen. So we can choosing a human tumor cell line, of course, express this tumor antigen. Then we can pick a PBMC donor. At our group, we actually have a PBMC donor connection. We already pre-screened this donor, so we know their cytokine induction potential, and we know their the engraftment, the cell type profile. So you can pick from our library, or you can provide your PBMC to us. So once we have this tumor cells growing this humanized PBMC double knockout model, we can treat the BiTE you're interested, and also including control, of course. So after the treatment, we'll closely monitor the mice conditions. So the readout would be the clinical observation, including the body weight, and we also can see the body condition score. Here, we actually establish a new system, so-called CRS score, to monitor the mice. The 0 will be very healthy, the 4 will be sublethal. And then we can monitor tumor, the growth rate, and then tumor inhibition through measure the tumor size, or imaging the tumor growth if the cell line express the luciferase.
Oh, right. Yep.
Yeah. Mm-hmm. And then the cool thing is we also can do flow facts analyze on the blood when mice in life, or at the ending point, we collect the blood and other tissues. So this way we can tracking down the immune cell change following the BiTE treatment. Of course, the human cytokine we also need analyze. We collect the blood at different time, and either mice in life or at the ending point to check the TNF-alpha, IL-6, or these important cell cytokines, human cytokines. At the ending point, we also can collect the tissues or blood for the his-path and histology and IHC analyze. So you can see all this readout will help us to evaluate this BiTE, what's their efficacy, and how's their CRS, potential CRS, induced CRS in vivo.
You know, it's really interesting. I like the way you describe it's not just about the tumor growth. There's changes to the immune cells, their engagement with the tumor, their states, and you can learn an awful lot if you're looking at all of the possible readouts. And actually, this reminds me, this is a great time to let those folks viewing to ask their questions. Ching and I are happy to entertain your questions. So as we're going through this, if you're thinking of things, please ask questions. Which reminds me, I have another question for you, Jing. You've mentioned CRS a couple of times. Are we in a position where we're actually able to understand the tendency of a therapeutic to induce CRS as part of an efficacy study? Are we getting data sets from one study on both of those?
Yeah, of course we actually the highlight of this model is like we can evaluate the efficacy, but in the meantime we also can evaluate the potential of this bispecific to induce the CRS in vivo. So because we don't, ideally the good bispecific is have a very good efficacy, but less the CRS induction. So we modified our system to the experimental design, so we can collect the blood to measure the human cytokine level in the blood after the BiTE treatment. Meantime, we also look the potential CRS-induced damage to, for example, to other organs. We see the tumor shrink, but we also want to know the other organ is intact, not get damaged by the treatment. I actually can give an example here. So this model will be good to evaluate CRS because the traditional, the in vitro study, you never can see the complicated, the cytokine release to other organ effect. For example, if we have one pair, the BiTEs, they share the similar tumor antigen, but the other arm, the T cell bind to T cells, either low affinity or high affinity. We do this 2 BiTEs experiment at the same time, and we notice that the mice receive the low affinity BiTEs have relatively lower cytokine induction, and the mice actually pretty healthy, not like extremely sick. Compare the mice receive the high affinity BiTEs, we find they have significant increased cytokine release, and the mice, like I said, CRS score is already reached 3. So by comparison, we will recommend it to using the low affinity BiTEs because it has similar the efficacy, but the mice looks pretty healthy. We think it have a very low chance to induce the CRS in vivo. Yeah.
That's really exciting. It's quite a step up in terms of the platform to be able to get very different kinds of assessments out of the same system. So we actually have a question from our audience, and it's actually a bit of a change in the topic. So we focused a lot on BiTEs, which are engaging T cells. But if you were interested in, let's say, a myeloid cell or an NK cell, would you still be using the PBMC engrafted platform?
Oh yeah, this actually a good question. So although like today, I majority focus on the T cell related to bispecifics. Like I mentioned before, there's a lot of the NK cell based, so they really ask good questions. So in this case, humanized CD34 will be the good model to assess the NK function. So JAX actually have a line, is the NSG-IL-15 line. This line can support the NK cell development. So I would recommend to using human CD34 IL-15 for the NK based the BiTEs, the bispecific. Yeah. So for myeloid, we have SGM3 line, and we can using humanized CD34 SGM3 lines. Yeah.
Oh, that's wonderful. So we've got different platforms to target different cell types and look at the different kinds of interactions. So I've got another question here, and this is the one actually I think I could answer. And it's if somebody wants to execute work or get more information, who do they talk to at JAX? And So for our global audience here, we have folks from Puerto Rico and India and California. We have an email contact. It's our technical science group called micetech@jax.org, MICETECH @jax.org. And for those of you who are based in APAC or Europe or the US, you have a local rep, and any of your local reps can connect you through. So I'll stop there and take a quick check to see if we have any more questions, and I'm not seeing any questions. So this is a great opportunity. We're coming up to the end of our time. If we weren't able to answer your question, or you were having a little trouble with the interface to get your question addressed, please feel free to send it to MiceTech. We'd be happy to follow up with you directly. And then I also wanted to remind everybody we have another event on Monday.
That's true. I forgot.
Which will be a deeper dive into oncology. Are you part of that as well, Jean?
Yes, actually, in fact, our whole group, we will have I'm glad you mentioned that, because today we just get touched a little bit, but the next Monday we will have more detail. We'll share our research experience. Like I mentioned, some the BITE, we will have a more detailed experiment data to share with you if you're interested too.
Oh, that would be great, actually. Seeing the data always makes for a deeper conversation. Well, that's it for me. I'd like to thank the audience again. We're out of time. We look forward to your questions and hope to chat with all of you soon. Thank you very much.
Thank you.